Hello, my name is Tallulah Anderson. I am a mom, I am a sister, I'm an aunt, I'm a pretty good friend, and I also happen to be a 3-time breast cancer survivor to thriver. I also am the founder of a breast cancer grassroots nonprofit. For me, my perspective on equity in the healthcare system centers around access to care, reducing racial disparities, and more inclusion within the healthcare system overall. The best way to create more inclusive healthcare experience is for those in the healthcare business to be more intentional on combating disparities, confronting barriers, and identifying that there is such a thing as implicit and oftentimes unrecognized for some reason racism. I think the best way to combat it is by acknowledging and then doing the work, not just talking about what you will do or what you can do, but do the work. And for me, that is transformative action.
Welcome back, Health Impact audience. We've got another session for you talking about diversity, inclusivity, and a variety of other topics which have been brought up in the last couple of years, specifically around how do we make healthcare more accessible as we're moving more and more to technology. Well, one would imagine that technology makes things more accessible, but sometimes, it actually makes things more difficult, that things that used to be accessible before now become inaccessible, but it doesn't have to be like that. And that's why I'm really loving the session that we have today, because we have multiple angles, everything from somebody like Jan, who's been through that accessibility problem in her own life, as well as Megan, who's worked on a variety of different solutions and things like that to help hospitals and health systems really make things more and more inclusive. And then finally, Dr. Erica Steed is going to teach us a lot about why accessibility matters more than compliance only. Like, shouldn't we care about the humans and patient experience more than the federal government guidelines and other things like that? So that's why it's going to be a great conversation. I'd love for maybe we'll start with Dr. Steed, do a quick introduction on yourself and your role at your company. We'll then go to Megan, Jan, and then I'll post the first question.
Thank you. It is a pleasure and honor to be here with this esteemed panel. Again, my name is Dr. Erica Steed. I serve as a dual role as the System Chief Operating Officer for Sinai Chicago Health System in Chicago, Illinois. I'm also the flagship president of our largest campus within Sinai Chicago. So we are the largest private safety net healthcare system, not only in the city of Chicago, but in the state of Illinois. Part and parcel of our charge is to really drive health equity at its best and to really eradicate healthcare disparities across the most vulnerable populations across the Chicagoland area. So it's a pleasure to be here today.
No, welcome. And you guys are doing some really, really important work at scale, right? They're doing important work in small is already hard, but you guys doing this at scale is both impressive and obviously very, very necessary. Megan, quick introduction.
Thank you. Thank you so much for having me as well. My name is Megan Carey, and I am from Common Look. I am a senior account executive here and have a lot of experience with once we recognize that there's an area that we can improve with accessibility, I come in and support the systems from small scale also to large scale on how we can actually make documents accessible for people at every single level. So I'm very happy to be having this conversation and be included on this topic. So thank you for having me.
Sure. And something Megan's going to teach us during this session is there are no excuses. right?
Mhm.
This stuff can be
True.
done. It can be done at scale. It can be done cheaply, and it can be done quickly, right? So we're looking forward to learn that from you today. Jen, quick intro.
So many of you might know me. I'm back again. Shahid, as you mentioned, I've had an experience of blindness in one of my eyes for 2 years. So I'm just happy to be at this point in my career. I think we're talking so much more about being proactive and inclusive and making sure healthcare is accessible, and then going, well, accessibility and access are two different things, but in many ways much the same thing. So when we forget to think about all the different subsets of people that we are trying to reach and engage, I keep trying to raise the flag to say, let's remember the people that have disparities with blindness, but also low vision. And the more and more people are moving into Medicare, more and more those people would like to see something in large print or in a format that they can actually read more easily. So happy to be here today, and thanks so much for having me.
Yeah, so as a software engineer, I've spent a lot of time in the last several decades working on Section 508, the American Disabilities Act, especially when it comes to digital. And several problems come up immediately. How do you test? What are patients and users expecting? And almost always we couch this in the idea of we have to do this because it's required. We have to do it because there's compliance. We have to do it because otherwise we can't release the software. And I found that that's always the worst way to go, right? You want to do this because it's the right thing to do. And unfortunately, healthcare does not always have monetizable, commercializable solutions for the right thing to do. So it is required, but I'd love for, Erica, if you can jump in and tell us, what can we look beyond the idea of just it being required as a compliance? Is there what are the arguments that one can use for senior officials and senior managers at the hospitals and health systems like you are to say, guys, let's not think about this as a requirement in terms of federal law, but because it's the right thing to do. And more importantly, it can pay for itself because of patient experience, increased revenue. Any thoughts like that on how you could convince executives?
Yeah, well, thank you for the lead in on that. Absolutely, really putting this into perspective. Yes, there are regulations behind this that are certainly driving it, but that shouldn't be the only rationale for why we choose to put the patient first and advocate on their behalf. So I think that as we really take a step back on this, in order to provide an optimal patient experience, we truly have to put ourselves in the shoes of all of our consumers and really anticipate their needs and understand how do we not apply a cookie cutter approach to assuming that we're addressing all of the care and concerns of our patient population, but truly we can actually incorporate them into the thought process of evaluating what best methods meet and exceed their expectations, really have a seat at the table to really be partners in this process with them. So most certainly, yes, there's a huge regulatory push, but I would argue that number one, this is the right thing to do. This is showcasing an example of how we can put the person at the center of everything that we do, and really work part and parcel to really deliver high quality care in a different type of way. And the other part that I just want to add to this is, oftentimes in healthcare organizations like Sinai Chicago Health System, for example, we strive for health equity. We truly want to eradicate healthcare disparities across the vulnerable, underserved, marginalized populations. But what gets missed in health equity is the health equity among disabilities, which I think is something that's often missed, because there are certainly disparities that show up in the form of lack of accommodations for the various disabilities. So that needs to be put on the front burner as opposed to the back burner.
I love it. In fact, that was such great advice especially the idea of diversity and inclusivity. starting with perhaps disabilities. So Jan, from your time back when you were also in the provider space, how hard is this to pull off? Like, if you actually wanted to do this, is this like monumental, climbing Mount Everest, or it's hard, but it's doable if you prioritize it appropriately?
Yeah, I don't find it to be that hard. What I do know is that everyone thinks it's hard. And then there's the barrier. So if we kind of think about the barrier, Shahid, I think is what you're kind of asking, is we think it's hard, and then we don't really think we need to do it.
Mhm.
So we don't think we need to do it because no one's asking for that. And I have this conversation every day, and I go, well, okay, how many people do you have that are blind or low vision? And the answer is we don't really have any idea. So if we really don't have any idea, then really we don't know whether it's needed or not. So I think, to Doctor's point here, is asking and being inclusive, announcing that we want to engage you, and then taking the steps to do that is what it really takes. And when we really look at the steps, then one wonders, well, how expensive is it? How many documents do we have to do, and how do we make that? And so they're thinking, oh, we need to rebuild systems and we need to do all sorts. It really isn't that. While it's true that a lot of developers aren't trained in accessibility, we can help get them trained and understand. We can do audits and things like that of websites. And certainly the industry is moving to digital. But I always remind folks that digital isn't for everyone. So again, if we're going to look at disabilities, are we going to just push everyone down a digital market when it isn't really everything? So accessibility encompasses print. We're still a lot in the print world in healthcare. It includes all of the same things around the measures of CMS: engagement, patient satisfaction, communication, outcomes. All of those things are impacted by it. And then digital absolutely has to be a part of it. But it's sort of a tag on, as I think of it. It's not building a system, it's making the system you already have in workflow better than you've got it today. It's very simple. Actually,
Love it. Love that advice. So Megan, you've heard from Erica talk about, it's for sure it's the right thing to do, no question there. It's the right business thing to do because you can actually make better revenue, increase patient experience, and that will improve your brand and of course drive more patients towards your brand than anyone else's. Jan is saying it's not climbing Mount Everest. Now, if that's the case, what do you think is holding people up from, especially because you know the solution side well, when you walk into organizations, what do they say to you? Like, how big of a problem do they feel it is? And then what do you say to Jan's point, which is, guys, it's not that hard. Here's why. Well, how would you react to that? Imagine we were a customer and you were telling us about how hard it is not. What would you start with?
Yeah, I think exactly on the points that you've already made, there is a stigma on the implementation part. So we do know it's the right thing to do, and we know that there's a need for it. So how do we do this? And that's usually when people are calling us, they've either been told they have to do it, or they have a million other things to do as their job, and now this extra thing's been handed on top of what they need to do, which then you're already coming in with this mindset that, oh, this is going to be challenging no matter what. But the reality is we've really evolved over the last 20 years in the accessibility space. And the technology is just continuing to change and grow so that it's not such a challenge to, when you think about accessibility on the front end, you can actually implement it very easily, as Jan was saying, but also just testing. A lot of people don't know if something's accessible or not. And that really is the first step. And they don't realize that there's end users out there that are going to your website to pull down a document and they can't access that information. And you may think it's accessible and it's not. So it really comes down to testing and to really implement processes that you can create accessible materials from the beginning. And that portion, those are the hugest steps an organization can take right at the beginning, is recognize and test and see if your documents or your site is accessible, and then focus on the creation part. If it's not accessible, let's not add to it. Let's not create more material that's not going to pass accessibility. And then the third step is what do we do with the stuff that's already there that now needs to be fixed? So we come in with a multi-layer solution, and no organization is the same, right? And nobody has the same volume. And there's a ton of prioritizing to do. Where do we start? But it's not hard at all when you recognize that there's an issue and start dialing in how we can create more accessible content, how we can fix the things that have already been created. There has been a drastic increase in technology over the past 20 years, even just the word accessibility. You know, when I originally started talking to people, they didn't even know what it meant. And to have people coming to us now and saying, hey, can you help us? We don't know how to create documents the right way. And it's really simple once you go through training and you learn how to do that. And to know that we're continuing to evolve. The more that we learn, the more that the software advances, the easier and easier that it gets. And that's, I think, is the main key. A lot of times I like to go back to like a building without a ramp to get to the door. You cannot even imagine nowadays where there's not a ramp for a wheelchair to get into a building. And so with accessibility, when it comes to your website, that's what you should think about. Would you turn away someone in a wheelchair because you didn't build a ramp? And then you also have to think about back in the day, putting a ramp may have been really hard for someone. You have to get permits, and it's another thing that a builder has to do. But we have to get to the point where it's just automatic. You know, it's a requirement when you build a building now that it has a ramp. It should be automatic that when you build a website, it should be accessible. Just otherwise, user experience, you're turning away clients that won't even get into the building.
No, I love that. In fact, turning away clients should scare the bejesus out of all of us in the senior executive realms. So Erica, can you talk about what are the maybe harder to identify areas where you may be turning away? So Jan mentioned low vision. We can think of things like deaf folks. We can think of all kinds of different disabilities. Can you think of and give us some examples? And I'll ask Jan and Megan to do the same, to say, look, this is not obvious, but this is a disability. And if you use accessible software, if you use accessible techniques, then somebody, maybe they're not low vision, they're just old like me, right? They wear glasses. Like, is that also a disability that you could take care of in the case of reading, small print on small phones? Can you talk about those that are like not obvious, but they are just as big accessibility issues that you could take care of pretty easily?
Yeah, so I first have to preface with really saying that our entire being at Sinai Chicago, we care for everyone, 100% of the population that seeks us for care, and we are in that service delivery area, regardless of where they come from, regardless of their specific needs, whether their disability, they have a disability or not, regardless of their ability to pay. So that is what we pride ourselves on. That is what our legacy has been built off of. So our goal and our true north focus is to ensure that no one gets lost in the mix, and that no one goes without, no matter what accommodation we have to make in order to provide that. And so sometimes it's to our detriment, just because we try to solve everything. We're trying to solve the world's problems. And yes, we try to boil the ocean through that approach. But I think that the efforts that we put in place to really accommodate for that are plentiful. I would say we have a intentional focus of not just having a focus on our patients and our families and our community. We actually make accommodations for our employees as well, who are also patients and consumers of our business. And one critical example that I want to share that really highlights this. We brokered a relationship with an organization that I feel my heartstrings pull every time I really think about this organization, the Chicago Lighthouse for the Blind. Okay, and This was a prior world, but I'm just jump-started conversations with them more recently for the purposes of providing care to our population. But in essence, we worked arm in arm to really set up an infrastructure that's seamless, where they're helping us to run our call center for access to care for our community. You can't tell whether it's the Chicago Lighthouse or our organization that is actually answering the phone. But one of the key mentions behind this partnership is a large proportion of their workforce is made up of individuals with disabilities that provides accommodation, like working hand in glove with the electronic health record providers to create provisions for the blind, provisions for those with visual impairments. Looking at, as we're addressing the specific accommodation of accessing patients into our health delivery system, they're really thinking very, very intentionally, very thoughtfully on, okay, if that patient has a specific need, and yes, we incorporate that within the screening process. How do we jump ahead and strategically incorporate adjustments to our workflow and our processes and our operations to meet that particular need? So those partnerships in that creative way is really helping us, because yes, our subject matter expertise and what we specialize in is one thing, but by partnering with an organization that does this best, and this is hands down what they do, that's a beautiful marriage that allows us the ability to fulfill our vision and fulfill our mission of caring for whoever, wherever they come from, regardless of whatever their obstacle or barrier to actually receiving that high quality care. So I'm just going to use that as an example, but we're trying to apply that across the organization in a multitude of capacities.
Yeah, I know. That's a fantastic, unobvious point. And that is, look, if you just also build this to be more accessible for your own employees, what that means is you can solve some of your hiring, retention, and other issues, which are huge right now, right? We can't seem to keep employees and staff members. And if you want to have better partners, if you want to have more extensions of your workforce, yes, make things more inclusive, and that makes your job a little bit easier for those areas. That sounds fantastic. Jen, anything unobvious like that from your side on what we might be thinking about accessibility?
I don't know if it's not obvious, but I think that as we move to consumer-centric healthcare more and more, I mean, this is becoming a commodity, right? We're used to going on Amazon and shopping. And so now more and more we're moving healthcare to that kind of, I think millennials want it. I think retirees want it, where this is how we're used to doing it, you know? So if we're leaving people out in that process because you can't navigate every step of the website, and it's amazing how many websites we navigate through, you know, the first 5 boxes, but you get to the 6th one and you don't know what goes in there. So the information that's now sitting in your portal, which is your EOB or your bill, it can't be accessed because you can't get past door number 6. We've got to build it so that every step of the way, whether it's digital or I love the on-ramp, you know, but then there's the rails. So the person in the wheelchair's got to go up, but what about the person who isn't in a wheelchair but needs to hold on by the rails? I think of that as a different kind of output. You know, maybe that's the print output, or maybe that's just the statement that they need, or their EOC or their ID card needs to be in a large format. So when they're on the phone, they can see what's on there to read the number. Or maybe they need a braille holder for that ID card. So when they're in their wallet, they can feel what that ID card is. Oh, that's my insurance ID card. That's the one I need to hand over. These are all ways to think about how we're really engaging that person at the level they need to be engaged. So that's how I think of, you know, where we're moving as an industry.
No, I think that's a fantastic advice. And in fact, you know, so you guys are much too nice to say it, but I will say it for everyone. And that is, if you're not handling accessibility, you don't actually care about your patients, right? You can have all the baloney marketing that you want. You can have all the baloney statements of how much you care. But the way you know you care is, I think Megan said it perfectly. Dude, if you don't even have an on-ramp, that means you don't welcome people in a wheelchair. It doesn't matter how much you say you welcome them, but you don't have an on-ramp. And I think that's a perfect way to look at these subject areas, especially in accessibility. So with Megan, with that, so actually, the more we talk about it, audience members might be hearing that maybe this is a lot harder than we think it is. So we've said it's not as hard as you think it is. Are there free resources? Are there people available? How do you get that testing going? Because I think that's probably the crux of all of this is, what's that first place to begin? It is like, we can see that there's no on-ramp in a building. We cannot see, for example, that there's no Braille access on a website or a PDF. So what would you say is the lowest hanging fruit, Megan, with respect to testing? And then I'll have Erica and Jen chime in as well.
Yeah, no, absolutely. I can go on and on about this topic, but the main of the solutions that are available, because we've really built as many resources as we possibly can. But to keep it short and simple, the main takeaways I would suggest is that we have standards. There's ADA compliance standards that need to be adhered to in order to pass the compliance. So there's testing tools that you can get that are free out there that will test to the standards. So my biggest point is, we don't know what technology the end user is using. So for example, air quotes, you don't know the type of wheelchair that an end user has, but you need to make the ramp cohesive for every wheelchair to get in. So that's why I really stress understanding the standards, because the standards are built so that it can work with all technology. So there are free testing tools out there that will test to the standards that you can get. And that's your very first step. And so a PDF comes from Adobe Acrobat, and you can test in Adobe Acrobat, but the standards aren't built in there. So you want to get a testing tool. So Common Look has a testing tool called the Validator. It's a free download. You can go to our website and we'll send you a copy of it. And you can test one document at a time. If you have no idea if it passes or fails, you can run it through. And then you're getting an idea of what the user will experience. If it fails, then you know that when someone goes to your website and they open that PDF, it will not read through their screen reader. That's like the bottom line of that. Then beyond that, if you wanted to test more than just one document at a time, and you had, we have some organizations that have 20, 30,000 PDFs on their website. You don't want to go through those one at a time. You can actually do a scan of your entire site. It will find every single PDF, and then it will let you know where those pass or fail. So it's easy because you're getting this information, and then we can go, what are we going to do to fix it? And once again, just going back to that end user experience, if it fails and it does not meet those standards, that is not going to be read through the end user's screen reader. And you just locked the door. You just locked the door for information for that client. So those two resources are my main recommendation, is test as much as you can to see if you pass or fail. And then if you know that you fail, find out why. Find out what you need to do to change, fix what's failed, and then how we can stop creating documents that don't pass. And that from there, there's a whole bunch of solutions that we offer to make it as easy as possible and to also financially keep it down. This is something that takes manual work, and this is another expense that we are trying to not add on to everything else in a full functioning organization. Because you don't want to add a price tag onto something that's giving material to people that they need. So you have to be very cautious of, if we create these differently, could we save a ton of money just creating them the right way? But my whole recommendation to my clients is test first. Let's stop creating content that's not accessible, and then let's find a solution that fits.
No, it's fantastic advice. In fact, so you probably have audience members who are listening to this saying, look, you had me at hello. How the heck do I convince my bosses to do this? Maybe we can say, is there a place to figure out is there technology available, means, techniques that you can say, look, here's how you analyze how many people are leaving your site because they can't access it. Is there a way of I don't know if it's a metric, if it's a calculation, something that we can show our bosses, hey, here's how many patients are leaving because they can't get through our website. What would you say, Erica, we can start with you, and then Jan and Megan, you guys can add as well. How do you measure how bad it is?
We incorporate within our organization, we have screening tools for everything. So given the population that we serve, we typically screen for social determinants of health, because our spin is really health equity. We've layered on top the requirement to be in compliance for ensuring that we are in tow with the ADA in terms of those accommodations. So on top of what we already screened for in terms of the social determinants of health and the other demographic features that we're looking for, we incorporate a screening thought process to ask about specific accommodations. Are you hard of hearing? Do you have any visual impairments? Are there any other disabilities that we need to account for, right? So, and that gives us a basic metric and measure that really sets the stage for that patient experience. So if in fact we're dealing with a specific population that's hard of hearing, and we have a large percentage, by the way, that have hearing needs, we actually have a dual focus. We have an in-person interpreter services type of component, but we also have automatic technical and technological features that really help to augment that. So we provide that concession. One specific area of our service is a focus of people with mental health or behavioral health type of challenges and issues specific to that population. That is a differentiator for our organization, where we actually have a deaf and language interpreter specific to the mental health population. So we've made accommodations that are triggered based off of that screening process that we have in the very beginning. And that screening process really helps us to understand our population fully. So it's not just breaking down to, again, racial and ethnic demographic. It's based off of the whole person demographic, including concessions for disabilities.
Yeah, and Erica, could you add the following also? We've talked about the fact that if somebody can't get into your building because you don't have an on-ramp, you've actually lost the patient. It's a bad business decision. You harmed the individual as well. But are there scenarios, Erica, that you can think of from your organization where by doing this with accessibility, you actually make more money? And money is just a proxy for value in this case. So you are more valuable because you do this. Is there a way of measuring that?
Yeah, absolutely. Because, and again, being one of a health system that has one of the freestanding rehabilitation centers, obviously it's been built with that thought process in mind. But yes, if in fact you as an organization, you reconstruct your operations and your workflows and your facilities to accommodate for these specific needs, now you're kind of like that anomaly. So now you're providing a service that is not spread wide, is not global or widespread to other organizations. So you're really creating a specific book of business for yourself that you can accommodate that others cannot. And that, to me, I think that is a consumer differentiator, and you're putting yourself out there as being the provider of choice, if you will, just because individuals will travel for accommodation, right? Mm-hmm. They don't just have to be within the immediate circumference of being within 5 miles of the organization. People will travel 50 miles, 100 miles to achieve the best level of care that meets and exceeds their needs.
That's fantastic advice. Jan, if you can add to that a little bit, think about your days prior when you were on the provider side, or even now. If I'm a hard ass executive. I'm like, I don't know. You got to show me where the money is. You got to show me. And a lot of people in healthcare don't talk like that on the outside, but they're saying that on the back end, right? So let's just talk to them and say, look, it's the right thing to do. You got to do it anyway. It's fairly easy to do, but hey, you can retain more patients and make more money, or get more patients, get more value. How would you make that case to senior executives that you're seeing today?
I think there's definitely an ROI. While we may not have the model that goes, A, B, C, there is definitely motivation and dollars at the end of the line from CMS when you have better engagement, when you have better outcomes, when you have higher star ratings, better HEDIS rates, when your surveys are positive with member engagement and members have a good feeling about you. That is worth money. And no one is arguing that anymore. It's more of a, okay, we've got to do something. We're up for doing it. We're just not sure we should do that. We're just not sure there's really a need. So I love what Dr. Erica is saying, because in all my communications with people that really are using disability services, it's all word of mouth. It's like, oh, I'll go 50 miles down the road because, that organization really knows me. I don't have to walk in and holler, 3 feet from an open desk during COVID to give out my social or my ID number because we had to social distance. These people were accommodating me. They understood that I needed to come in and, give that information. So this is where we're going, and we've got to include everyone. So I just think, I often talk about the Medicare population. There's more and more people going into Medicare. There's more and more systems accommodating Medicare. And again, if vision isn't an issue in Medicare, I don't know. You can have a lot of really healthy people, but they have vision issues. And if you want to engage them and you want to keep them happy and you want to retain them and have their outcomes, you're going to have to be communicating them in a way that they can understand. So ask them what it is they need. It's really that simple. Ask them what format they need. Would you like us to communicate with you in a different format? If yes, what is that? Great, we can accommodate that. You're going to do all of this digitally? Great, we'll be there for you in that way and make sure that meets. We can do audits on websites that are already set up. We can help build websites from the scratch up. We can remediate the documents you've already got. I mean, so a lot of those are just first steps. Let's just tick them off as we go along. It's not, it's not a huge project, I guess is how I really see it for those that are implementing it with us.
Perfect. And with the last couple of minutes that we have, May, I'd love for you to kind of synthesize this following concept that we know it's not terribly difficult to do, but it is real work. So if it is real work, where should you start? We talked about testing already. Maybe computing an ROI is the right thing to do. But when you come into an organization, are you often scratching your head saying, why the heck did you guys start here instead of there? And what would that early advice look like to say, hey, guys, you're doing that the hard way. Let's start at this one place after testing. You got to do the testing first, right. But where do you start? Is it PDFs? Is it your website? Where do you start?
Great question. It's a matter of the organization, how they want to prioritize, but they all do sort of swoon together, and we do look at the actual documents. So that's another key component, is anytime we can get samples from an organization, that really helps us out to understand the workflow, and understanding how the document is built really helps us to be able to provide a solution. So every organization is going to be different, but not only with their documents, internally, they're going to be different. You're going to have different marketing material versus, an EOB versus an invoice. These are all different ways to handle the documents, but it's all under one big umbrella. So usually with organizations, we try to prioritize what has the biggest need right now. Like some people will say, we're going to start with invoices. And so we can work with them to make sure that every invoice that they send out is accessible. And then some people say, no, it's just all our marketing material. All of it has to be accessible from right now going forward. And then some people, you mentioned something about, your documents on the outer facing website, but then internally for your employees, some people start with, everything that's facing out, we're going to make accessible. Then we're going to work on our internal documents. So there's different phases. One is never above the other. It's just a matter of prioritizing them and really looking at the samples, because anytime that we can help you create the sample to be more accessible, you're knocking that out right there. So usually on my first, conversation with people, I ask them if they can send me as much as they possibly can send me, and tell me the volumes that you have, and what in your opinion would be your biggest priority. And then we would sculpt together a solution to fit all of those needs.
No, I love it. This is fantastic advice. I knew we'd have a great conversation here. We're out of time now, but just to summarize, what I love, the example that Megan gave about the invoices seems so drab and meaningless, but if you want to get paid, that's probably a good place to start, is just make sure all your invoices are accessible. And on the marketing side, that's where you're saying, I want to focus on patient acquisition, patient retention. So I'd almost suggest here that as senior executives, especially those who are trying to convince a senior executive, give them a business reason, right? Like, we can get $10,000 more a year paid just because our invoices are accessible, is a great way to start the conversation, because it's not nebulous and it's not arm wavy, kind of like what I'm doing now, but it's very specific to either patient acquisition, patient retention, getting paid. Those are, unfortunately, healthcare is still a business, a perfect place to start. With that, thank you so much, Dr. Erica Steed. Jan, great to have you again. Megan, you're part of our Health Impact team now, so hopefully we'll see you as often as we do Jan and Dr. Steed. So with that, thank you, everyone.
Thank you.
Thank you
so much.
Enjoy the conference.
This is great.